Welcome, everyone, to this month's um, seminar on spirituality and health. And today I'm thrilled to be able to introduce John Petit, Dr. John Petit. Dr. Petit is a full professor. Uh, that's a correction from what I sent out around. He's been promoted to a full professor in the Department of Psychiatry at Harvard Medical School. After receiving his MD from Columbia University, he completed his medical internship at UNC in Chapel Hill, just down the road from us here. He also completed a residency in psychiatry at the Massachusetts Mental Health Center and a fellowship at the Peter Bent Brigham Hospital in Boston. For over 40 years, he has been a psychiatrist at Brigham and Women's Hospital and at the Dana-Farber Cancer Institute, where he is professor of psychiatry at Harvard Medical School. A distinguished life fellow of the American Psychiatric Association, he has received several teaching awards and published numerous papers in the areas of psychosocial oncology, addiction, and the clinical interface between spirituality/religion and psychiatry. He has co-authored or edited 14 books, including Doing the Right Thing, An Approach to Mental Issues in Mental Health Treatment. Moral Issues in Mental Health Treatment, which is the subject of his talk today. He's also published a book called The Soul of Medicine, Spiritual Perspectives and Clinical Practice, and the book, The Virtues in Psychiatric Practice. He is a recipient of the American Psychiatric Association's Oscar Pfister Award and is past chair of the American Psychiatric Association's Caucus on Religion, Spirituality, and Psychiatry. So it's with great pleasure. He's also a close friend who I've known for many years. So it's with the privilege to be able to introduce him to you all. So John, take it away.
Thank you, Harold, for that kind and generous introduction. It's wonderful to be here, and I'm really looking forward to getting some feedback from folks on these ideas. So let me see if I can share my screen again. Can everyone see that?
Yes, we can see it. It's full screen. It looks good.
So although we implicitly act to further the good of the whole patient, I find that as clinicians, we're frequently shy about the place of moral values and virtues in treatment, but also that this seems to be changing. So the subject for my talk today is the psychiatrist and the moral life. What are we learning? Here's an outline of what I'm hoping to have us consider. Well, first, a little bit about definitions of morality and the moral life, the historical context of morality and psychiatry, the new DSM code for moral problems, some clinical conditions in which we engage these moral problems, a therapeutic framework for doing so with some case examples, and then some possible future directions and resources for further learning.
John.
Yeah.
John, is there any way you could speak up a little bit? Some people are having trouble hearing you.
Is that any better?
Oh, a lot better. Thank you so much.
Okay, let me see if I can continue to do that. Tell me if it is not as good anymore. So in terms of definitions, the terms moral and ethical are often used interchangeably to refer to patterns of interaction among persons that constitute living well as a community. The moral life can be viewed from a philosophical perspective, but from a functional perspective, it involves, as discussed in the book pictured here, developing and sustaining a conception of goodness as a basis for one's moral identity, implementing commitments to do what's good and right, making moral decisions among competing values, assessing whether one's behavior is consistent with one's moral identity, dealing with moral failure, and acquiring morally admirable character traits or virtues. There's a long history of attention to morality in psychiatry. In the 18th century, reformers such as Pinnell in Europe and Benjamin Rush, the father of American psychiatry, pioneered more humane care for the mentally ill and what came to be known as the moral treatment period. Some disorders, such as addiction, were also conceptualized in terms of vices to be avoided and virtues to be encouraged, as you can see here in Rush's moral thermometer. But in the 19th and mid-20th century, Sigmund Freud saw morality as a cultural means of controlling the id by imposing unrealistic demands. He famously said in his Civilization and its Discontents, "The commandment, love thy neighbor as thyself, is impossible to fulfill." Michael Foucault also expressed one of the most common and persistent reservations about including morality within the clinician's purview when he described the, quote, moral asylum as, quote, not a free realm of observation, diagnosis, and therapeutics. It's a juricidal space where one is accused, judged, and condemned. And then in the 1980s, the brain disease model began to be contrasted with a moral model of mental illness, as in the popular book, The Broken Brain by Nancy Andreasen, who became the editor of the American Journal of Psychiatry. Warning against moralism further, in the 20th and 21st century, psychiatry saw a growing emphasis on the therapist's neutrality in psychoanalytic work, on unconditional positive regard in the humanistic therapy of Carl Rogers, and on combating toxic shame in the more recent popular work of Brene Brown. But there were concerns raised about the limits of acceptance. In 1973, Carl Menninger pushed back with his book, Whatever Became of Sin, arguing for the importance of personal responsibility. And in 1966, the University of Chicago sociologist Philip Reif published The Triumph of the Therapeutic, Uses of Faith After Freud, in which he described the emergence and dominance in Western culture of, quote, psychological man, who stands for nothing, consistent with Freud's psychology of analysis and detachment. Despite Menninger's warning, mental health clinicians continue to suffer a reputation for avoiding moral aspects of human behavior and being overly permissive. James Mumford published a piece in the New Atlantic in 2022 entitled Therapy Beyond Good and Evil, on his experience with an ACT therapist as an exercise in moral relativism. And I recently noticed an example of this in season 3 of Doc Martin, where a psychologist is shown defending his son's defacing of neighborhood cars by asking if wrongness isn't just a matter of opinion and no one else's business. In recent decades, the neurobiology of morality has become an object of study. Research has found that it involves a complex network of brain regions that integrate cognitive, emotional, and social processes to guide moral behavior, with key areas implicated in moral cognition, including the prefrontal cortex, temporal lobes, cingulate cortex, and default mode network. The growing field of neuroethics has spawned fascinating philosophical questions about free will, responsibility, and the ethics of neural modification of behavior, as exemplified by this book by Matt Baum here at Harvard, and with theories of morality popularized by public philosophers such as Jonathan Haidt, Sam Harris, and Poul Zak. These theories have recently been critiqued by a book, Biopolitics After Neuroscience, Morality and the Economy of Virtue, co-authored by Andy Michael, one of our former residents here. But these are beyond the scope of this talk. Several philosophers have offered helpful clarifications. Lee Bishop has pointed out that technical equipoise does not require moral neutrality, and that the kind of autonomy that's a goal of clinical work is mastery rather than freedom from influence. Eric Matthews argues that therapeutic goals imply a kind of moral vision, consistent with the emphasis in DBT on aiming for a life worth living. And Duff Waring at the University of Chicago goes further in his book, The Healing Virtues, to show that therapists have a role in cultivating virtues such as self-love, self-respect, and empathic concern and respect for others, since attaining these as sufficiently stable states amounts to positive mental health. And Gerda Klaas, who's a residency training director as well as a philosopher in the Netherlands, describes our discipline as having an intrinsic normative or values-based structure. Even more consequential has been the emergence and growth of positive psychology. In 1998, Martin Seligman, considered the father of the positive psychology movement, chose character strengths and virtues as his theme for his term as president of the American Psychological Association. As he put it, quote, "The main purpose of positive psychology is to measure, understand, and then build the human strengths and the civic virtues." Virtues referring to pathways toward good ends. This graph shows the growth in the positive psychology literature since that time. You can see the impact of positive psychology in fourth wave or growth-oriented therapies, such as the interventions enhancing gratitude, personal strengths, and meaning for patients with heme malignancies being studied by Hermio Mono, one of my colleagues here in Boston. Jennifer Radin, a philosopher at UMass Boston, and John Sadler, a psychiatrist at UT Southwestern, extended an emphasis on virtue into the clinician's role in their 2010 book, The Virtuous Psychiatrist, discussing these virtues you see on the left-hand side as core to the psychiatrist's effectiveness. And in my edited volume on the virtues in psychiatric practice, the chapter authors suggest ways that clinicians can understand the role of virtues in both their work and in the recovery and growth of their patients. Virtues of self-control, such as equanimity and humility, benevolence, such as forgiveness and compassion, and of intelligence, such as practical wisdom, and positivity, such as gratitude and hope. In recent decades, there have been a number of developments fueling a growing concern with the negative side of the moral life. Boundary violations have led to an explicit emphasis on ethical behavior as the defining feature of professionalism in the ACGME's required competencies. Clinicians who work with survivors of trauma have been the primary contributors to the literature in approaching the moral problems in treatment. In her classic book, Trauma and Recovery, Judith Herman points out that a therapist may need to provide, quote, "a context that is at once cognitive, emotional, and moral," unquote, in order to help the survivor reconstruct a coherent system of meaning and belief that encompasses the story of the trauma. Jonathan Shea coined the term moral injury as distinct from PTSD after working with veterans of the Vietnam War. And the COVID-19 pandemic brought to the fore the widespread moral distress and burnout experienced by clinicians, so that the APA published a document on moral injury in COVID-19. And even more recently, we've become familiar with the moral outrage and pain over national and world events that our patients bring to us, and that we ourselves feel when we listen to the news. Last year, a number of us, including Harold, with a major contribution by Seth Mattson, who's a psychiatry resident at MGH, proposed to the DSM-5 steering committee of the APA, which was chaired by Paul Applebaum, the creation of a Z code for moral problems. And in January of 25, the APA trustees approved the proposal. As you may recall, Z codes are not disorders, but are conditions that may be a focus of clinical attention or treatment. They reflect social determinants of mental health. They emerge from the V codes in DSM-5 with the publication of ICD-10. An example here is the V code for religious or spiritual problem introduced to DSM-4 in 1994, proposed by David Lukoff and Francis Liu. Moral problems were added to this Z code for religious or spiritual problem to describe problems that are related to an experience that disrupts one's understanding of right and wrong, or one's sense of the goodness of oneself, others, or institutions. The data that went into this proposal dealt primarily with three types of moral problems. Moral distress, historically defined as a situation in which an individual is prevented from acting ethically due to external constraining factors. A lot of this came from the nursing literature. Moral injury, the combination of exposure to a potentially morally injurious event and the subsequent sequelae of guilt, shame, self-condemnation, betrayal with difficulty forgiving. And moral dilemmas, there's a lot smaller literature on difficult decisions due to competing ethical values causing distress. Next, I'd like to talk a bit about some of the clinical conditions in which we see moral problems and where there's a moral dimension to the treatment. Just to go back to moral distress and moral injury, you can see these definitions again. Last year, Litz et al., who was the first person to introduce the term moral injury into the scholarly literature, Litz and Walker published a paper in which they showed a continuum between moral challenges, such as global warming on the left-hand side, that may lead to frustration, to moral stressors, such as failure to protect others, as in medical errors, to moral distress, to morally injurious events, such as acts of cruelty or grave injustice that may lead to moral injury. And I think, Harold, you've recently published in the Journal of Religion and Health a paper addressing this issue of a continuum and whether cases at the extreme of moral injury should be considered for a potential diagnostic category. You can see here differences in experience depending on whether one is a victim, a perpetrator, or a witness. Shame-based consequences are likely for a perpetrator, and trust-based consequences, anger, betrayal, or mistrust, for a witness or a victim. This slide just shows some of the literature that we summarized in the proposal for considering moral distress and injury as a Z code. Just note a couple of these. In a study of veterans in active duty military, over 90% of 373 US veterans reported high levels of at least one moral injury symptom, and 59% reported 5 or more symptoms. In a study of the 25 peer-reviewed studies of US healthcare professionals, one with an N of 1945, found that 40% of individuals were experiencing moderate to severe distress from moral injury. In a study of clinicians during COVID, only 8% of respondents reported never having experienced moral distress during the pandemic. There have been dozens of published scales for measuring moral injury, with the moral trauma assessment emerging as one of the most recent. And there have been papers on moral injury interventions published, including acceptance and commitment therapy, CBT, spiritually integrated CBT, healing through forgiveness, EMDR, and various pastoral care techniques aimed at fostering self-forgiveness and social re-engagement. Harold is more of an expert in this area than I am by far. Just cite a case example here that we can come back to later when we think of how you might approach it. A man in his early 20s, completing inpatient detox from alcohol, revealed that he began to drink to deal with childhood sexual abuse by an authority in his faith community. Here's another, a patient in treatment for cancer told his therapist he was more distressed by ongoing events in the news than by his cancer. So medical mistrust is another area, which is often marked by a loss of faith in goodness and requires us to restore trust by conveying our integrity and concern as part of trauma-informed care. And you can see some of the elements here of trauma-informed care: the principles of safety, trustworthiness, choice, collaboration, and empowerment. Addiction is another area where we see moral issues emerging. When I was working as a medical director of an alcohol and drug clinic, I came to appreciate how powerful it is for some of our patients with alcohol use disorder to complete a fourth, fifth, and eighth step. Take a fearless moral inventory, confess it to another person, and make amends as a way of dealing with their moral failures, or what sometimes they call in AA the wreckage from the past. Demoralization. Treatment of a demoralized suicidal patient can require us to lend the patient our hope in goodness. Jerome Frank, who is known for his book Persuasion and Healing, and his followers emphasize the importance of hope in psychotherapy. And as Viderman and Perry write in their classic paper, the life narrative, by its very nature, conveys to the patient that he is worth understanding and by implication is therefore worthy. Depression is frequently connected with moral concern, since it so often involves struggles with one's moral identity. First, negative emotions such as inappropriate guilt, shame, contempt, or disgust, and regret are common manifestations of depression. One study found that 80% of a study population with major depressive disorder had self-blaming emotions. And the DSM-5 recognizes as one of the core symptoms of major depression feelings of worthlessness or excessive inappropriate guilt nearly every day. But realistic or true guilt can also lead to depressed mood, for example, as a contributing factor to suicide risk following incarceration. Third, individuals subjected to coercion, abuse may internalize shame and guilt in ways that increase their vulnerability to depression. I think of a nurse and former nun who left the order after seeing its practice of self-inflicting pain as mentally damaging, but continued to feel guilty over pursuing her own interests. Fourth, complex PTSD can contribute to depression, and in an interesting study of 240 psychiatric inpatients published in 2017, Becky's et al. Found that the impact of childhood trauma on present borderline personality disorder and PTSD was mediated by moral injury and shame. I'll come back to complex PTSD with a case example later. At the same time, depression can also be an occasion for moral reassessment, improved insight, and growth. Narcissism and psychopathy are somewhat different from the other moral problems in that they typically cause others more distress. They typically reflect stunted conceptions of goodness and a lack of empathy and compassion, among other prosocial virtues. We don't have an empirical consensus about the most effective way to treat these conditions, but mentalizing, helping individuals take responsibility are often advocated as principles. Finally, the literature on moral dilemmas in various settings documents associations with anxiety, depression, and burnout. Patients may present for treatment to us with distressing dilemmas with a prominent moral component, such as whether it's right to divorce, how much to sacrifice for an aging parent, whether to forgive a childhood abuser. Individuals' moral commitments often have roots in their faith. Their ways of dealing with moral failure are often shaped by religious beliefs and practices, and their development in virtue is often supported by their faith community. We also know the nature of distress caused by moral problems generally can be spiritual in nature and lead to disillusionment over values that one has held sacred. Here's a third case example for us to think about. A woman in her 20s with OCD and pervasive anxiety felt like what she said was a horrible person because of having to live with and depend financially on her family. So in terms of therapeutic approaches, I'm suggesting a threefold approach to such moral problems. First, clinicians can validate the importance of patients' moral concerns rather than avoid or reduce them to psychological processes. A book that makes this point well is Arthur Kleinman's What Really Matters, Living a Moral Life Amidst Uncertainty and Danger. Judith Herman's recent book, Truth and Repair, is another in which she highlights the need of trauma survivors for acknowledgement and vindication. We can also see this emphasis on taking patients' core values seriously in acceptance and commitment therapy, or ACT. And it's the point of the new Z code for moral problems to recognize them as worthy of clinical attention in their own right. Second, clinicians can engage in a dual process of clarifying, addressing their psychological and moral dimensions. For example, Barr in 2022 et al. Came to advocate a, quote, dual track approach to the treatment of traumatic illness, addressing, in addition to dysregulation of fear and memory systems, disturbances in value and character domains. For example, quote, through reflection, self-forgiveness, repentance, and restoration. Similarly, Litz et al. Have argued for a yes and rather than a yes but approach, going beyond traditional behavioral approaches such as CBT that assume a normally operating conscience and address distorted beliefs associated with guilt and shame through contextualization. To suggest that therapists may also need to deal directly with issues of guilt, forgiveness, and making amends. The point is not to privilege one or another approach, but to integrate them depending on what the patient needs. And third, clinicians can identify resources for functioning morally by engaging the patient's values, again, an important feature of ACT, the ultimate ground of their ideals, the virtues upheld by their particular tradition, the role of faith communities in supporting them. Spiritually integrated cognitive processing therapy developed by Pierce et al. Has emerged as one method of doing so. And spiritual psychotherapy for inpatient residential and inpatient treatment developed by David Rosmarin at McLean is another example. Forgiveness. It's worth noting now that there's an extensive empirical literature on forgiveness interventions, which work to help individuals overcome the anger and resentment that hold negative beliefs in place and serve as barriers to actualizing virtues such as love and compassion. Both Everett Worthington and Robert Enright have developed somewhat similar models of achieving forgiveness. A workbook for using Worthington's REACH model has been shown in a randomized clinical trial with over 4,500 participants across 5 countries with a history of relatively high conflict to be effective in increasing forgiveness, reducing anxiety, reducing depression, increasing hope, and increasing individual flourishing. Here's another image from the Litz and Walker paper showing elements of a treatment plan to treat moral injury by promoting values and valuing pro-social experiences and attachments. You can see that examples of this include AA facilitation, cognitive therapy, mindfulness, spiritual practices, etc. As another example, a local colleague of mine, Kevin Majors, who teaches CBT for anxiety, has has described replacing a vicious cycle of negativity and avoidance with a virtuous cycle of reframing, mindfully considering one's ideals, and taking action. He draws heavily on Thomas Aquinas in the way that he does this. This framing overlaps with the approach to demoralization suggested by James Griffith at George Washington in his paper on hope modules. He's also recommending individualizing interventions based on what is behind the patient's loss of hope. So now I'd like to come back to these case examples, what one might do in treating a patient like this. I think in addition to approaches directed toward PTSD and alcohol use disorder, one would want to identify the moral emotions, betrayal or shame, in this case, as evidence of potential injury, and available resources for restoring his sense of goodness of himself and others, including God. Was justice done or accountability achieved? In the second case, I think one might want to validate the distress of witnessing morally injurious events, offer strategies for limiting toxic exposure to the news, and explore options for acting in solidarity with others. A third example, the woman in her 20s with OCD. In addition to treating the anxiety, one would want to acknowledge her concern, help her put it into context, and explore options such as disability for repairing her sense of goodness. Here's a little more on a case of complex PTSD. A late life seminary graduate in her 60s with an abusive childhood and marriage was hospitalized for worsening depression with suicidal ideation. She described chronic dysphoria, irritability, sensitivity to rejection, and difficulty continuing to believe in a God who could create me so damaged. Medications and CBT were unhelpful. Over the years, she came to trust a generally supportive therapist. Eventually, she was able to participate in a small congregation where she felt known and loved and able to recover her faith in goodness. Another case, quote, codependency. A woman in her 20s presented with anxiety, sleeplessness, and the use of prescribed narcotics to cope. She's clearly distressed about being unable to get her husband to stop drinking and to stop covering for her brother's shady business practices. Her history included serving in the role of a family mediator before her parents divorced when she was 13. After reading a popular book, she decided that she suffers from codependency. I think in an integrated treatment, a therapist would try to help her clarify her standards and her reasoning. To what extent has she felt obligated to help others, even at her own expense? How did her view of herself as the family caretaker develop? How does she understand and weigh her duties toward her husband, her brother, and herself? Going further, a therapist might also ask, does she also need help to reassess her standards? Has her role as a family peacemaker shaped her genuine moral commitments or distorted her ability to weigh her own interests? Does she need help to make her goals more achievable or realistic? What resources or role models can guide her in making these decisions? And then a final case, successful salesman is brought by his wife, who's threatened separation because he remains sarcastic and verbally abusive to her after 20 years of marriage. Although he admits he's, quote, not proud of behaving like a jerk at times, unquote, he does not seem to be distressed enough about his behavior, nor to understand that his wife is about to leave him. In an integrative treatment, a therapist might ask, does he need someone to enhance his capacity for empathy and mentalizing, which would then have a bearing on his capacity to experience guilt and recognize moral failure? And does he also need help in addressing what interferes with his failures to live up to the ideals that he does have? Does he have insecurities, habits, marital dynamics that need to be addressed? There are, of course, clinical and ethical challenges involved in addressing moral problems in treatment. For example, how can a clinician remain aware of and best way the patient's and the clinician's personal, tradition-specific, and professional values? How can a clinician avoid exerting undue influence? How can one deal authentically with differences between the patient's and the clinician's values? The first step I would suggest is to be aware of our own values and moral commitments. In a paper I've found helpful in thinking about engaging moral and religious questions in treatment is this one by Farr Curlin and Daniel Hall, in which they make the case that instead of being guided by the ideals of autonomy, competence, and neutrality that you see on the left as traditional ways that we think about these issues, we're better guided by those of wisdom, respect, and candor. So to conclude with a summary of what I think we've been learning over the past few decades, psychiatry, like medicine, is a moral and a scientific discipline. Psychiatry is a scientific discipline in investigating disease and humanistic in investigating the experience of the patient. It's moral in being altruistically committed to patients' best interests and flourishing. Psychiatry encourages health-related values and virtues such as care, respect, and responsibility. It depends on the clinician's moral character. And good psychiatry is concerned with the patient as a whole person, including her moral functioning. These broad considerations shape the particular roles the clinician has in caring for the patient, including working with distressing moral problems, and often through leading by example. What about future directions? Should we expect to see a case made for moral injury disorder, the way the case was made for complicated grief disorder, as a more severe form of a normal phenomenon? As we learn more about the neurobiology of moral functioning, is it feasible or appropriate to consider intervening to modulate disabling shame? What can we learn from work being done already with substances such as psychedelics, given their impact on the default mode network? Given the connections between moral and spiritual life, what kinds of collaboration with spiritual care providers such as chaplains make sense? And are there ways to better understand the informal ethics embedded in everyday clinical practice as the development of moral capacities? By comparison with the top-down abstract application of principles, conversations in supervision and process groups of residents, which I've hosted for several years, have often touched on how to deal with unfairness, how to best stand up for what's right, how to course correct. The 2025 open access book by Stephen Scher of McLean and Kasia Kozlowska, Revitalizing Healthcare Ethics, the clinician's voice, is a very helpful and readable way, I think, to better understand this process of developing what they call our moral capacities during the process of informal bedside ethics. And finally, I'll just mention a few resources I think that can be helpful in dealing with the moral dimension of our work. The Harvard Medical School Center for Bioethics, led by Brenda Brendel, has just celebrated a 10-year anniversary. The Edmund and Lily Safra Center, also here at Harvard, recently hosted a roundtable event on mind, madness, and morality. The Human Flourishing Program at Harvard, founded in 2016 by Tyler Vanderwill, looks at how quantitative social sciences can be integrated with the humanities on questions of human flourishing. And Tyler was a contributor to the proposal for the new Z code. The Hippocratic Society is a more recently formed organization devoted to fostering virtues in medical practice. It has chapters in a growing number of academic medical centers around the country, including at Duke and Harvard. I mentioned the Spirit program led by David Rosmarin. And in addition to these options that are mostly local to me, the Association for the Advancement of Philosophy and Psychiatry has an annual conference publishes the journal Philosophy, Psychiatry, and Psychology. The annual Conference on Medicine and Religion, which was just held in Houston, invites interdisciplinary folks to talk about such issues. The Islamic Bioethics Project, and the program at Duke on theology, medicine, and culture are all other places where these conversations can take place. And I'd like to express my gratitude to all of these folks at these places who've helped me to think and learn about these issues, and from the opportunities like this to hear from what the rest of you are thinking. So thank you for your attention.
Thank you, John. So let's open it up. If there is anybody who would like to ask a question, simply unmute yourself and show your video and ask your question.
John, this is Patrick Kelly.
Hi,
Thank you
Patrick.
for the, hey, it's good to see you again. Thank you for the synthesis. I'm in primary care, and I remember some of you know Dan Fountain. I've mentioned him before. He was a missionary in the Congo from 63 to 96, and essentially essentially developed a primary care infrastructure for the entirety of the Congo when he left 35 years later. At any rate, he said in one of his talks that I heard before he died, I think I was a second year medical student, he said something to the effect of 90%. I mean, he was a physician and a surgeon, and he was doing unbelievable work. I mean, he was in the operating room sometimes all day, but he had a primary care practice as well. And he said 90% of the problems that he saw were spiritual in nature. Now, that was whatever. I mean, I guess that was 15 years ago. I've been in clinical practice in New England, and now I'm in the South, and I wholeheartedly agree with that statement. I mean, the medicine honestly is pretty easy, and it's very rare that people have like a really complicated medical pathology that takes like all this sorts of research. It's typically pretty obvious medically what's going on, but it's very, very, very much complicated by the patient's own life and the patient's own history, especially if there's a history of abuse or neglect, and especially if it's sexual abuse and childhood abuse. Like, it makes a medical pathology take on entirely new dimensions. So I guess my question to you would be, given that, well, number one, do you agree with that statement? I guess is number one, and then number two, how can we in primary care learn from what you're doing in psychiatry and integrate them into clinical practice?
Yeah, I'm not a primary care doc, but from talking to them, I know that those issues do come up and are very relevant to the kind of work that you're trying to do with people. I think you could have a similar acknowledgement of the importance of these moral and spiritual issues, and approach them within the context of your relationship with the patient. I've thought more about this in terms of psychiatry than primary care, so maybe other people have more ideas about that.
Angelica?
Yes, I'm Angelika Zollfrank. I'm the chaplain at McLean. Dr. Petit, thank you
Hi there.
so much for your wonderful presentation. It was truly amazing how much you gathered in terms of information and approaches. I was wondering how, in an inpatient setting, you see the best way for chaplains to collaborate with psychiatrists around spiritual, but also moral issues, and what you see as effective in making sure that psychiatrists are calling on chaplains when that's particularly poignant to do, since we're often such a stretched resource.
Yeah, well, you could probably answer that better than I can, being where you are and working with David Rosmarin. It's been a while since I worked on an inpatient unit. I think the more chaplains can let the clinicians know when they have had interactions with patients, so that they recognize that they're part of the team, and when they have time, be part of rounds and discussions. At the Brigham, we have the palliative care chaplain come to our rounds every other week when we talk about cancer patients. And we try to identify cases ahead of time that we've both been working with so we can learn from one another in rounds about what we're doing. And that's on a medical setting. I guess a lot depends on the culture. You know, if you have a culture that's open to it. I know you've had David had said his spiritual consultation service too at McLean, which is, I think, an interesting model.
Yes, definitely, and it's working. I guess I'm always looking to expand that and see what resources there might be to make the case actually even in terms of research in that particular area.
Yeah, that's a great question. I think I saw George Facette on the call. He's pioneered some of these ways to quantify what chaplains do as maybe a basis for doing better research in this area. That's again not an area that I'm an expert in, but I think the more we can come to some consensus and shared language about what we're doing, probably the better. Harold, you may have thoughts about this too as a researcher.
Yeah, I'd be interested in what George had to say. George, can you make a comment on that if you're available there?
Friends, yeah, thanks. It's a great topic, Angelica. I think it's really good that you brought it up. I think we ought to look for opportunities to collaborate with psychiatrists to kind of begin by being descriptive to what extent are moral injury issues actually components of the distress that patients are feeling? To what extent are they being addressed in the treatment? To what extent are chaplains being included in that treatment so that we kind of have a baseline about what's going on? We can pick one or two kind of clinical populations perhaps to kind of initially describe the need and describe the care that's being provided and the gap perhaps around what care is missing. And then, begin to do better research about interventions that include intentional use of chaplains to kind of test the effectiveness of those. So I think there's a lot of opportunity for some informative research in this area. And I think a kind of critical question would be to find partners for that research. And, my colleagues and I, Transforming Chaplaincy, and certainly Angelica, as part of that project, we'd be happy to kind of do that research and begin to have a clearer picture of when chaplains are being used well, when they could be used better. As a great opportunity for research there. But I also, just want to say, John, thanks so much for the presentation. Really, as Angelica said, a wonderful synthesis of the information and the themes, and look forward to kind of continuing to learn from you.
Thanks, George. I believe Jonathan Scott has been wanting to say something, and then Antonio. So, Jonathan?
Yes, I know that the veterans have done groups for moral injury, which have included psychologists and chaplains working together as facilitators, as at least one area where chaplains are with the mental health professionals are part of a team.
Yeah,
And
could I jump in
yeah,
there, Jonathan? One of those modalities is called building spiritual strengths. It's an intervention that was developed by Irene Harris, and a number of randomized clinical trials have demonstrated its effectiveness. And you're right that those building spiritual strengths groups are co-led by chaplains and mental health professionals, and they have a version of it actually for use for moral distress, moral injury in health professionals. So that's been adapted for use there. I'm sorry to cut in. Yeah.
oh no, that's fine. I was just wanting to raise that up as the group dynamics as a area where um, morality and spiritual and uh, psychological issues are dealt with as a team that includes chaplains.
Yeah, that's great.
Good. Antonio, I believe you're up next. We can't hear you. We cannot hear you, Antonio. Still cannot hear you. Okay. With regard to where you can learn more about building spiritual strengths, there have been a couple of randomized controlled trials. If you were to put that into your Google Scholar, you're going to come up with those papers, and that might be a good place to see what's happening there. Patrick.
John, have you had any experience with the Building Spiritual Strength resource, just personally?
No, I haven't, unfortunately.
Does anyone else on the call have experience with that?
I'm aware that they meet, as a group for 2-hour sessions, typically in a religious setting, in a religious congregation in the community, goes on for 8 different sessions. And the focus originally had been on PTSD, but it includes now issues around moral injury, etc.
Thank you.
What are the limits of a military chaplain's role when dealing with issues such as moral injury? John, can you take that one? That's from Antonio. What are the limits of a military chaplain's role when dealing with issues such as morality without overstepping the boundaries of medicine or psychology? Says Antonio from Brazil.
Yeah, that's an interesting question. I mean, I think I usually think more about the limitations of the clinician's role. I always feel as though the chaplain has more freedom to do what they want. But I would think in the military, you might also have concerns about whether people are going to be seeing you as part of the establishment, and whether they're going to feel it's free to talk about feelings of betrayal as they would be in another setting, if they see you that way. Maybe other people who've worked in the VA can speak to this.
Anybody working in the VA here that could help out? Okay. Angelica has a comment here in the chat. Chaplaincy Innovation Lab. Those are all capitalized, those letters. Chaplaincy Innovation Lab has an intervention manual online available on one Google's Developing Spiritual Strength. So that's good to know about that. Let's see if there's anything else in the chat here. Thank you. This is from Paul Houston. Thank you for sharing your insight and healing work, Dr. Petit. How do you suggest we think about the relationship, psychological suffering, affordability crises around the world, and the moral life? The relationship between psychological suffering, affordability crisis around the world, and the moral life. Any thoughts on that, John?
Well, I guess I'm aware of moral distress on my part when I see the affordability crises around the world worsening sometimes. And I think, again, being clear about what I might be able to do in my own role, and about the importance of these issues with other people, not just to think about them, but to take whatever action I can, are things that make sense. I'm not sure if affordability crises means also the availability of resources for people to deal with moral issues, because that's another issue. I mean, not only physical health care, but mental health care and spiritual care are just so lacking in many places around the world.
Yeah, that is so true. We have time for maybe a question or two, and then we will conclude. Anybody have anything they would like to ask? Take advantage of John's wisdom. There are lots of thank yous to John for your presentation. Dr. Snell has a comment in the chat. See if I can read it here. So this is from Dr. Snell. Dr. Petit, thank you for your most valuable presentation on moral injury and moral trauma. How would you approach the patient who has a 5-year history of psychiatric and pastoral inpatient treatment and all else for treatment-resistant depression with zero change to chronically anxious behavior, social withdrawal, distant engagement with church activities, and Bible study attendance with detached behavior? So that's quite a question. Let me repeat it here. So how would you approach the patient who has a 5-year history of psychiatric and pastoral inpatient treatment and all else for treatment-resistant depression with zero change to chronically anxious behavior, social withdrawal, distant engagement in church activities, and Bible study attendance with detached behavior? So maybe somebody with chronic mental illness and kind of detached behavior. Any thoughts, John?
Yeah, it's challenging because I mean, I think as we see people who could benefit from spiritual help, we try to explore what's getting in the way of their getting that. But then if people are so stuck that they can't do those things, we often need to focus on the psychiatric side of it and try to also recruit whatever support we can from their faith community during that process, without putting too much pressure on them to have a religious response, because sometimes that happens too, right? When you get the religious community involved, patients can feel a lot of expectation from them. So I think it can be challenging, but if someone has a faith from before that was helpful to them, then continuing to work to reconnect them, I think, has got to be part of the treatment.
Good, good, excellent. Okay, everyone, we are at time. So thank you, John, for this brilliant presentation. And thank all of you for your input and for your listening. We'll see you back next month.
Thanks.